Good afternoon, Dr. Shraddha.
Good afternoon, sir.
गुड
How are
आफ्टरनून।
you?
Yeah,
Dr.
good
Upinder, कैसे हो? Good afternoon.
बस आपके राज में है सर। बढ़िया
मेरा
है।
राज यार। प्रधानमंत्री, प्रेसिडेंट तू, राष्ट्रपति तू और राज मेरा।
सर इतने खिल रहे हो आज, तो एकदम स्पेशली दिख रहे हो। कुछ तो आज स्पेशल है क्या? कुछ
नहीं यार, कुछ नहीं
यू आर लुकिंग सो फ्रेश एंड स्मार्ट।
यार, तेरे को मिलने आया हूँ तो फ्रेश एंड स्मार्ट तो रहना पड़ेगा।
बात करना तो कोई आपसे सीखे। गुड
और
गुड।
क्या चल रहा है?
कल एएपी के कॉन्फ्रेंस जा रहा हूँ।
अरे वंडरफुल, कंग्रेचुलेशंस।
उन्होंने 30 मिनट दिए बात करने के लिए। एएपी आईपी का रोल इन चाइल्ड हेल्थ पॉलिसीज में, इन रेफरेंस स्पेशली अर्ली चाइल्डहुड डेवलपमेंट।
अच्छा, वंडरफुल वंडरफुल।
या थैंक यू। हमारे बंदे किधर गए सब? आया महेश आया।
Hi, sir. Good afternoon, sir. Good afternoon, everybody.
Hi Narmada, how are you?
Hi. Yes, sir. Doing good, sir.
Very good.
किसी को भेज दें कि मेरे को कुछ पानी वानी दे। पानी, हाँ, हरीश को भेज।
सर मेरे लिए भी एक चाय भिजवा दे को बोला।
बोलो कितनी चाय चाहिए?
बस एक ही।
कटिंग।
मुंबई वाले आप तो जानते हैं कटिंग।
कटिंग कटिंग चाहिए है।
Hi, good afternoon.
नमस्कार मोहिते सर।
Namaskar.
संपली ओपीडी?
हाँ, OPD संपली.
Hello, sir.
Hi, hi.
Hello Dr. Shraddha, how are you?
Hello, sir. I'm fine. How are you?
Absolutely great. Dr. Siddharth and Dr. Preetham have not yet joined.
Hello.
Namaskar.
sir.
Hello. Hi.
Yeah, good afternoon.
Good afternoon.
Good afternoon,
Hi.
President sir.
Preetham sir, congratulations.
Oh, thank you. आपको sorry.
बस ठीक है यार, बड़े हो लोग।
Thank
बड़े
you.
लोग, बड़ी बातें।
Thank you. मोहिते सर कैसे हैं?
बहुत बढ़िया, एकदम
Hi,
बढ़िया.
Dr. Shraddha. Hi.
Yes, hello, sir. I'm fine. Yeah.
Yeah.
चेतन
राजेंद्र।
हमको भी कांग्रेस बोलने का मौका दो। क्यों बोल रहे?
छोड़ो ना, अभी नहीं, मैं बाद में फोन करूंगा। रहने दो,
Okay.
उपेंद्र मेरी खिंचाई कर लेंगे।
FIP के लिए।
अच्छा. ओके यस. महेश पण आहे ना?
हो मग आहे ना, म्हणून तर महेशला केलंय ऑलरेडी.
नर्मदा ऑल्सो हो गया ना उनका भी लास्ट ईयर।
2021 में ही हो गया सर एक्चुअली।
सीनियर है मेरे से।
नहीं सर।
चेतन हमारा नहीं हुआ है अभी तक।
आप अभी छोड़ दो, आपको नहीं मिलेगा।
आपको अभी नया बनाएंगे कुछ.
हाँ,
कुछ नया अलग बनाएंगे अभी.
Somebody has logged in from 2 devices.
Yes.
Myself sir, just joined.
I was just about to say.
3 or 4 years ago, somewhere in Nagpur or somewhere, they gave all past presidents as a whole and soul FIP, if I don't mistake. All
If
past
somebody has
presidents who had not received it, they gave it in a lot. And Vijay and all they got at that time.
Right.
Now it is in the constitution itself.
What?
Those who have not received after they remit the office, they get it.
अभी वो देने वाले हो गए हैं, वो लेने वाले नहीं रहते हैं।
चेतन कैसे हो?
अरे सर, हाउ आर यू?
मैं ठीक हूँ यार, आप बताओ।
ऑल गुड सर।
गुड।
आप हो सके तो रीनेम कर दो सर।
क्या रीनेम करूं?
नीलिमा भंडारकर का नाम आ रहा है तो हम गुड आफ्टरनून मैडम बोल देंगे।
अरे आई डोंट नो
कोई बात नहीं सर, चलेगा।
यार मेरे को ना इतनी अकल नहीं है इन चीजों के बारे में।
नहीं, no problem, sir. I think DIP people, can you rename sir Dr. Anupam Sachdeva? DIP?
कौन है, श्वेता है क्या?
Please type on the chat box.
नहीं, Dr.
नहीं
Anupam
नाम
Sachdeva is
शी से नाम उनका टाइप करके दे दो तो मिस्टेक नहीं हो जाए।
हाँ, मैं लिखता हूँ।
It's 4 o'clock.
मेरी थोड़ी सी ना नजर भी कमजोर है।
Not an issue, she is doing it, don't worry.
Yeah, sir, we'll do it.
Dr. Mahesh, shall we start?
Yeah, we should.
Yeah. So good afternoon, friends. Welcome to this yet another episode of Academic Pearls, the Tuesday academic activity which we have started on 1st of January. Myself, Dr. Upendra Kenzavadekar, President of Indian Academy of Pediatrics, along with my colleagues, Dr. Mahesh Moite, Dr. Chetan Trivedi, Dr. Nilima Bhandarkar, Dr. Narmada Ashok, Dr. Rajendra Vaidya. We all welcome you to this wonderful academic episode. And today we are on to hematology series, as you must have seen since last week. And today we have a great combination of mentor-mentees and Dr. Anupam Sachdeva, who is our past president of Indian Academy of Pediatrics, but more importantly, a great, well-known, highly acclaimed hematologist from Sir Gangaram Hospital from Navi Delhi. And then, of course, along with him, Dr. Shraddha, Dr. Siddharth, and Dr. Preetham are the mentees. And with them, we are going to have a fascinating journey of hematology and going to get practical insights. The feedback that we have received from this program is almost 80% of those who log in are practicing pediatricians, and they find the tips which are given over here in this program are extremely useful, and about 20 to 25% are the PG students that log in for this program. So great to have all of you, and let's continue this academic journey with the help of all my dear friends. And over to Dr. Mahesh Moite for further proceedings.
Thank you, President IIP, Dr. Upendra, for that wonderful preambles as usual. Today we are continuing our session. The last, actually, this is a penultimate Tuesday. As per our previous record, mentor-mentee used to be the last Tuesday, but for some kind of conveniences of the faculty, we had slightly reshuffled it. The next Tuesday is going to be a solo talk by Dr. Revati from Chennai. So today we have our program, which is mentor-mentee, where the kind of format is such that very senior pediatrician hemato-oncologist, Dr. Anupam Sachdeva sir is going to be the mentor, and he will be guiding the three faculty, which actually is not, I would say, students. They are themselves in the faculty or senior fellows, and they are given individual topics. So Dr. Shraddha and other two, Dr. Siddharth and I think Dr. Preetham, they will be taking individual topics, and on the way we'll be sort of discussing the topic and taking Q&A at the end. So I request Dr. Narmada to introduce the faculty, and then subsequently Dr. Anupam Sachdeva to take over. Dr. Narmada, please.
Good afternoon, respected seniors and all the IAP members who are here as well as watching on the DIAP platform. It gives me great pleasure to introduce the faculty of today. Of course, if everybody has introduced already Dr. Anupam Sachdeva, a very well-known IAP, past IAP president, as well as who is also the heading the Pediatric Hemato-Oncology Department and BMT unit of Sir Gangaram Hospital. He also happens to be the co-chairman of Department of Pediatrics, and he is a recipient of the very prestigious BC Roy Award and the Silver Jubilee Research Award. Sir has, with his rich experience, is going to guide us. And also, we are going to listen to the inputs of his mentees, Dr. Siddharth Totadri sir, who's qualified, who's done his fellowship from DM from PGI Chandigarh. He is now pursuing a pediatric 1-year bone marrow transplant and CAR T-cell therapy fellowship at Mazumdar Shah Center at Bangalore. And he has been previously Associate Professor of Pediatric Hemato-Oncology at CMC Vellore. And he has numerous publications to his credit. Joining him here, we'll will be Dr. Preetam Singha Roy, who also has done his pediatric hemato-oncology from DM Chandigarh, and he is now the junior consultant at pediatric hemato-oncology unit at the famous Tata Medical Center, Kolkata. And with numerous publications to his credit, I'm very sure he will add to the discussions today. And he's joined by Dr. Shraddha Chandak, who has done her FIAP at in hemato-oncology, and she is presently the consultant of KPOND's super specialty hospital at Sambhaji Nagar, and also the president of the Happy Kids Foundation. So that's a very interesting name, because we always associate pediatric hemato-oncology to something. It's a nice name to be kept. And she's the executive board member of AAP, and also she has authored many books and has numerous publications to her credit. And a special area of interest is in benign hematological disorders and inborn error of immunity. Together, these faculties are going to tell us what is the latest advances in pediatric hemato-oncology that will benefit we as an office practitioners. So the stage is yours, sir. Over to you.
Thank you very much. Who's the first speaker, please?
Dr. Shraddha, please.
Yeah.
Dr. Shraddha, sir.
Yeah. Just tell them to Dr. Shraddha, could you please share your screen?
Sure,
And
sir.
the good news is that the pediatric hematology oncology has come on, has matured into a adolescent thing, because yesterday only we came to know that the National Board of Examinations has recognized pediatric hematology oncology as a full-fledged specialty, and from 2025 onwards we'll have diplomate or a DM program from National Board of Examinations also. So it's a very good news that our branch has come up to age. I think Dr. Shraddha, can you please go ahead?
Yeah, sure, sir. Thank you so much. Am I audible and screen is visible?
Yes, ma'am.
Absolutely, ma'am.
Yeah. So good afternoon, everyone. First of all, I would like to thank DIP platform, Mahesh sir, Upendra sir, and all dignitaries for giving me this opportunity and to share my thoughts over here. So it's a great pleasure to meet you all, even online. So before I start my talk today, I'm going to talk on autoimmune hemolytic anemia. But before I start, I would like to acknowledge all my teachers, my colleagues, my friends, and my patients, my parents, because of whom today I am here. So today we are going to see what is AIHA. So it's a state of decompensated acquired hemolysis caused by host immune system acting against its own red cell antigen. So we have our immune system, which is consist of B cells, macrophages, antibodies, and they are acting against our own RBCs, and that's why it is causing hemolysis. So basically, we have this is disease which is all running around our RBCs, IgM, IgG, and complement. So we are going to listen all these terminologies in next 10-15 minutes. So incidence of this is a quite rare condition. Generally, incidence is 3 to 4 per lakh per year. It is seen all over ages. So from young children till elderly. But in the young children, it is warm type of AIHA, which we see more commonly as compared to the cold agglutinin disease, which is the disease of middle age or elderly. The median age in pediatrics to have AIHA is generally 3.8 years. There is no specific racial background attributed to AIHA as we see in sickle cell disease or thalassemia. Again, male and female both are equally affected, though there is one study which says that young male are more prone for AIHA as compared to female, but it is not compulsory always. So the natural history of this disease, generally, the most commonly, there is some etiological factor, and most common being some infectious etiology. So child is having some febrile illness, some critical illness, followed by this AIHA, and therein there is an antibody titer which is increasing, decreasing, there is relapsing remission course, and then disease resolves or stays back. But the most common prognostic and important prognostic factor for AIHA is presence of mixed type AIHA or presence of IgG and C3b both together. So those patients are having this mixed type of AIHA. They are more prone for this chronic relapsing AIHA. The mortality.
Dr. Shraddha,
Yeah.
your slides are not moving.
Yeah, moving, sir, moving.
No, we are seeing still the definition slide.
Yeah, because
Oh,
sir,
I'm sorry. I'm sorry.
describing. I'm just speaking. I've just
Okay,
moved
please
this
go ahead.
point.
I'm sorry. Please
No,
go
no
ahead.
problem, sir. So mortality rate. The mortality rate of AIHA is generally 11 to 18% previously, but now it has decreased to 4% because of the newer modalities of diagnosis, treatment, and newer drugs and the sophisticated supportive care. With this introduction, we'll go to see the classification of immune hemolytic anemia. So generally, immune hemolytic anemia is classified into three: autoimmune, drug-induced, and alloantibody-induced. But today we are going to mainly deal with this autoimmune. So we will concentrate on this part. So autoimmune hemolytic anemia again classified into four different types. That is warm reactive antibody, cold agglutinin disease, paroxysmal cold hemoglobinuria, and mixed type. So out of this paroxysmal cold hemoglobinuria, it's a benign transient condition. Mainly most commonly it is seen in children. Median age is around 5 years and it is post-infection and which resolves over the period of time. So along with this, what more important for us being pediatrician is the warm reactive antibody, because that we see most commonly. So warm reactive antibody can be idiopathic when there is no etiology is found, and or secondary mainly to SLE, that is connective tissue disorders, or some underlying PIDs or the primary immune deficiencies. The same here, cold agglutinin disease can be idiopathic. As I said that it is more common in the middle-aged or elderly, it is most commonly seen secondary to the underlying malignancy and most commonly being CLL, that is chronic lymphatic leukemia or infections. So infections can be parvovirus, EBV, CMV, mycoplasma, treponema, anything. Pathophysiology of AIHA, which is most important, it can be let's understand what happens in the warm type. So we have our RBC. Now they are attached or they get sensitized or some agglutinin, that is IgG type, and that is of Fc portion or Fc receptor, they get attached to RBC. So RBCs are getting sensitized. Now this Fc receptor attached RBCs, they are identified by our splenic macrophages, and these splenic macrophages, they causes Fc receptor mediated phagocytosis of these RBCs. They take them to the spleen where they are sequestrated. Some of them get lysed and some of them get escaped. Those who are getting escaped in the circulation, the part of membrane is removed in the spleen, and that's why RBCs lose their discoid shape and they become rigid and spherical, and that is what we famously known as the spherocytes, and that's what we see. So more the spherocytes, more is the hemolysis. They are directly proportional. While what happens in the cold antibody? So it is a IgM mediated hemolysis. So here it is RBCs, they are attached, since IgM is a pentavalent antibody. So one antibody can attach to 4-5 RBCs. Now these RBCs, when there is a high thermal amplitude, then they get attached, and generally this attachment takes place in the peripheral circulation where temperature is lower down, and therefore it is responsible for some degree of acrocyanosis. Now when this attachment occurs, the complement activation takes part by the classical pathway, and C3b, it attached to this complex. Now, when these RBCs, sensitized RBC with Fc, IgM and complement, they get into the normal circulation, the IgM is released, but C3b remains attached to the RBC. Now, this C3b attached RBC, they are taken up by the liver macrophages, very famously known as Kupffer cells. And those macrophages, they lyse RBC in the liver. So this is how there is an extravascular hemolysis occurring in spleen as well as liver in warm and cold agglutinin disease respectively. So what is the basic difference in the warm and cold? So as we said, warm generally most commonly we see in the pediatric age group, but even to some extent in adults also, but cold mainly in the elderly. Antibody type is IgG, while cold it is IgM. Temperature at which hemolysis is maximum is 37 degrees Celsius in warm type, while it is 4 degrees Celsius in the cold type. Mechanism of hemolysis is opsonization in warm, while it is complement mediated in the cold antibody titer. The site of hemolysis is spleen, while site of hemolysis is liver in the cold one. The blood smear, if we see, we get a spherocytes in the warm, while we see the autoagglutination in the cold antibody. And DAT, that is direct antiglobulin test, or which is formerly known as a DCT, it is positive with IgG antibody, while it is positive with C3 antibody in the cold one. So the clinical features, as I say, that most commonly this AIHA is secondary to some underlying illness. So generally we see there is a history of fever, cough, cold, headache, child may be hemodynamically decompensated, chest pain, but most importantly, what we notice is the pallor, which is sudden onset, which may be noticed by physician or parents, and the icterus, dark colored urine, and a variable degree of organomegaly. So investigations in AIHA. So basically investigations we divide into the two parts. The first is the primary evaluation to document that yes, there is a hemolysis, and the second part is to investigate for the underlying etiology. So the primary evaluation consists of a hemolytic screen that includes CBC retic PS, which goes in hand, bilirubin, LDH, DCT, haptoglobulin, and urine hemosiderin. So this all consists of your hemolytic screen. So CBC, what it will show? It may show normocytic to macrocytic anemia with or without low platelet count or normal. If it is low platelet count with AIHA, definitely we can think of Evans syndrome, but here we won't go into that detail. The PS, peripheral smear, again, it shows loss of central pallor, macrocytic, normocytic, bizarre shaped picture. There are spherocytes. These are the rigid small spherocytes. There can be some Haynes bodies or remnant of the RBC, and there is polychromasia, nucleated RBCs can be seen. Retic, since it is hemolytic, retic will be high. Reticulocytosis is seen, but not always. There can be reticulocytopenia is seen in AIHA when the AIHA is secondary to bone marrow infiltrative disorders, or maybe the etiology is parvovirus infection, or maybe there is an immune attack by these antibodies on lead precursors of erythroids, or there might be marrow is little bit lagging in giving the retic response. So not always we will get a reticulocytosis. That thing we need to keep it in mind. Unconjugated bilirubin will be high, definitely because of the breakdown of RBC. LDH, which is a marker of cellular turnover, it may be beyond thousands. DCT or DAT will be positive, will come in next slide. Haptoglobulin will be reduced, generally level is less than 8, and urine can be positive or will be positive for hemosiderin. Now, what is DAT, or formerly known as a DCT, direct Coombs test? So generally, let's remember this very simple. When we call this at a DCT, it is in vivo, what is happening inside our body. And when we say it is ICT or indirect antiglobulin test or IDAT, that is, it is happening outside the body. So in DCT, if we understand the principle, our part is very easy. So there are sensitized RBCs with all these antigens. Now, with this sensitized RBC, if we add anti-sera, which is anti-IgG AAG reagent, when it is added, that time coagulation takes place. And this agglutination can be seen in test tube like a precipitate, or it can be seen under microscope. So that time we say that it is DCT is positive, and it is labeled like 1+, 2+, that degree of agglutination. The same thing, ICT. Now here, the antibodies are from the patient's sera. They are added to the reagent erythrocytes. Now these are the nascent erythrocytes which are coated or sensitized with the antibodies from the patient. So now the scenario becomes like this in DAT. And now the anti-sera is added additionally. And that time, if we see the agglutination, that means that ICT is positive. So generally ICT says that the antibodies are present in vitro. Generally, we do this ICT in cases of HDN in mothers to see the presence of antibody titer. So detection of the second part of evaluation is detection of underlying disorders. So this should not be missed. So viral markers like CMV, EBV, parvoviral markers like PCR studies, then infectious screening like mycoplasma pneumonia, which is the most common cause for the cold agglutinin disease. Then treponema pallidum screening, especially in the adults, not in pediatrics. Connective tissue disease markers like ANA, which is like a window to the CTD, double-stranded DNA, serum immunoglobulins. Most of the time, AIHA can be the first presentation of the underlying immunodeficiency, like ALPS or CVID. So extended LSSA, the DNT, double negative T cells should be done. The imaging, CT scan, abdomen, chest, pelvis can be done to rule out any lymphoma. And bone marrow evaluation, as I said, not in pediatrics, but if we are suspecting underlying leukemia, bone marrow is needed. And lastly, here I have mentioned NGS. Now, initially, anybody will say, why NGS in AIHA? Again, I am saying the AIHA doesn't come isolated. There may be some underlying etiology which may not be obvious on our routine screening. So sometimes to find out the molecular diagnosis, especially of underlying immunodeficiency, NGS may be needed, but not in all cases. Differential diagnosis, yes. If there is a hemolysis, there can be a non-hemolytic anemia, like most commonly hereditary spherocytosis, because we are seeing spherocytes in AIHF and spherocytes in HS also. But there will be a family history positive, DCT will be negative. There may be history of cholecystectomy in the parents. So that is how we can differentiate. Clostridial sepsis, ABO-RH incompatibility will show spherocytes. Severe burns, severe hypophosphatemia, their PS will show the lot of spherocytes. The Wilson's disease, again, AIHA can be the one of the manifestation of the Wilson's disease, and in some cases CDA, that is congenital dyserythropoietic anemia. So this is the diagnostic algorithm. I think it might not be that clear, but I'll just read out very simply in just 30 seconds that once the patient is coming and we have done baseline investigations, we have seen, or with history and examination, we are suspecting hemolysis on the basis of if there is a history of acute febrile illness and sudden onset pallor, icterus, dark color urine, and it is giving us a clue, yes, am I dealing with some type of hemolysis? We have done hemolytic screen. We have ruled out family history, drug history, any other illnesses, associated illnesses, in adults, pregnancy status, past medical history, hypertension, everything has been asked and ruled out. We have thought that says we have to do the DCT. Now, if DCT is performed and it has come negative, but still our suspicion is very strong that yes, I am dealing with some hemolysis, which is autoimmune, the DCT can be performed with more sensitive tests such as microcolumn, solid phase, or washed or triple washed cold saline washes RBCs can be done, or we can perform a Donat-Landster biphasic hemolysis if we are suspecting PCH and still it is negative. We will think for some other causes, rare causes. Now, if DCT is positive, with anti-IgG plus anti-C, and cold agglutinins are negative, that is, it is not positive at the cold temperature, we label it as a warm AIHA. While if DCT is positive with anti-IgG plus anti-C and even cold agglutinin titer is positive for more than 1:40, then it is mixed AIHA. While if DCT is positive with anti-C, negative with anti-IgG, and cold agglutinin titers are high, then it is a cold agglutinin disease. And all time repeated DCTs are negative, all rare causes are still included, still retic is high, we are suspecting hemolysis, then very rare entity like DCT negative AIHA. So the treatment, let's give emphasis on the stabilization of patients. See, investigations can wait, evaluation can wait. What important is the patient's life? So if you see the patients coming to your casualty or PICU, which is debilitated, hemodynamically unstable, so just make him relax, admit oxygenation, supportive treatment, IV fluids, if there is a fever, antipyretic, treat underlying etiology. That is the most important part to treat the AIHA, because AIHA is one of the lingering disease of hematology and it needs lots of patience. Again, since there is a hemolysis, there is erythropoiesis is increased. So always patients are in a state of folate depletion. So folic acid supplementation is must for the erythropoiesis. In cold agglutinin disease, avoid cold stimuli. Keep patient warm. Give warm saline infusion. If you have to transfuse, give warm the blood bag externally and then transfuse. So transfusion therapy. Now this is a very tricky situation. If I'm saying that I have a patient with AIHA and I have kept it without transfusion, anybody will take a doubt. But let me tell you clearly, transfusion is indicated only in moderate to severe anemia. If my patient is stable, hemodynamically stable, hemoglobin is more than 9, and patient is reliable and we can observe him, transfusion can wait. Don't hurry in giving transfusions. But if patient is having moderate anemia, hemoglobin from 6 to 9, but patient is hemodynamically unstable and patient like tachycardia, low BP, headache, then the transfusion is mandatory. And in severe anemia, if hemoglobin is less than 6, irrespective of the status, clinical status of the patient, transfusion is must. But how we are going to transfuse? You are saying that AIHA is there, DCT is positive. How we are going to get the cross match? Again, the cross match, generally these antibodies are against the RBCs or the blood group antigens. Okay, so if we are able to exclude the alloantibodies, cross match is still possible. But what here I am saying that we should have a direct talk with blood bank officer. We should inform them the clinical status of the patient and we should ask for the least incompatible blood. So if the patient, if is not an organ transplant recipient, if there is no underlying mortality, if patient is not priorly transfused multiple times, then this transfusion can be safely given, but the amount is 10 to 15 ml per kg depending on the hemodynamic stability of the patient, status of the cardiac function. It should be given slow transfusion over 4 to 6 hours under monitoring. If possible and ideal situation, it should be given under steroid cover. Injection methylprednisolone 1 to 2 mg per kg. IV can be given before transfusion and then transfusion can be given. But the mainstay of the therapy of the AIHA is the drug therapy. So let's come here. So there are multiple drugs. Multiple drugs are coming and still more are coming in our literature to help us for this AIHA. But the gold standard and a very efficient drug, and as we know, we have been using since ages, is the corticosteroid. So generally corticosteroid prednisolone is preferable. Oral, as max to max, whenever it is possible, we should go for oral drugs. So 1 to 2 mg per kg per day in divided doses along with the antacid support or after the food as a routine precautions. How we give the mechanism of action, what prednisolone does, it decreases the antibody titer, it suppresses the splenic macrophages, it decreases the sequestration of the RBC in the spleen, and therefore the survival of RBCs is increased, and that is how the hemolysis is controlled with the steroid. And when the steroids act, so if we are giving today, are they going to act tomorrow? No. Steroid generally takes 7 to 21 days to give us the positive response. So we have to have the patience. As I said, that AIHA is a game of patience. So 7 to 21 days, it takes time to respond to the steroid. again we have to taper. Like once we achieve the complete remission, we are generally giving this high dose of the steroid for around 4 to 6 weeks, and then slow tapering is advised almost by 10 to 20% dose, and this steroid should be given with minimal doses at least for 3 to 12 months after remission is achieved. So we have to go very slowly with steroids. Again, the benefits are coming with side effects. So definitely we all know the steroid side effects. We have to monitor and we have to counsel the patients for the same, especially the adolescent one. Next is IVIG. As we have seen the role of IVIG in ITP, but sadly the IVIG is not that efficacy, has shown efficacy in AIHA. So IVIG being expensive, not very effective, it is reserved those who are not responding to the steroid or other line of treatment, not very famous. Rituximab, now this is what is the miracle. This is anti CD20 monoclonal antibody, and it is acting on the B cells. So it suppresses the B cell proliferation. It causes complement mediated cytotoxicity. And now this is very famous. Now it is labeled as a second line of treatment in warm AIHA, while it is given along with bendamustine or simply rituximab as a first line treatment in CAD, that is cold agglutinin disease. Again, the dose is 375 mg per meter square per week, should be given for around 4 to 6 weeks. Doses are there. Again, time to response is around 4 to 6 weeks. So we are not going to see the miracle immediately. But the side effect is the hypogammaglobulinemia, severe immune suppression, activation of hepatitis B, PML, that is progressive multifocal leukoencephalopathy. So it is quite a toxic drug. Splenectomy, yes, the splenectomy and rituximab are like equal, but again, this is something surgical, interventional. Post-splenectomy, opportunistic infections, thromboembolism, the risk is very high, and not that commonly done splenectomy nowadays, which used to be done in the prior. Now the next, when steroids have achieved the level, rituximab has gone, but still AIHA is not controlling. So we have something known as steroid sparing agents. So like azathioprine, cyclosporine, cyclophosphamide, MMF, danazole, all these are immunosuppressant acting at very different levels, and these are steroid sparing agents. But again, these drugs will also take around 1 to 3 months to see the response. So we have to wait. Once we start the drugs, we can't do that. This month I have started azathioprine. Next week I'm going to start cyclosporine. Next week I'm seeing DCT still positive, so I will start MMF. We can't do this. So we have to see the clinical patient clinically, DCT, compliance of the patient to the drugs, and then we have to take the decision. Again, we have to monitor the side effects of all these immunosuppressant accordingly. Then next, so the standard treatment of warm AIHA is the steroid, azathioprine, cyclophosphamide, MMF, and very rarely splenectomy. But as I said, if all new drugs are coming in the streams, and there are multiple target therapies are still in the trial for this warm AIHA. The most common we have seen is the rituximab with or without bendamustine, bortezomib, then venetoclax, sirolimus, anti-mTOR. Then we have C1q inhibitor, that is complement inhibitor, ANX005. But these are all under the trial. So there are these are the newer drugs. This is the reference from the ASH publications, recent ASH publication, and these are the newer antibodies they have suggested for this relapse refractory AIHA. So when we are calling it as AIHA being RR or refractory to the treatment. So if we are treating the AIHA for around 1 year, and still it is not responding, if there is relapses occurring for more after 1 year again and again, then it is called relapse refractory AIHA. So there are multiple antibodies, interleukin-2, daratumumab, sirolimus, abatacept, fostamatinib. They are being trialed. Some are in the open phase trial, some are on the case reports, like individual based are done, and maybe in future we will be having these drugs with us to treat AIHA. So take home message. So first and foremost is very important to establish a correct diagnosis. The treat underlying etiology is most important. Avoid unnecessary transfusions. Medication is the mainstay of therapy of AIHA, but ensure the compliance, monitor the side effect of drugs, and the most important is the patients, not only for the patients, but also for doctors and parents, because it's most lingering and most slowly resolving the disease, that it really checks our patients. And thank you so much for your patient listening to me. Thank you so much.
Thank you, Dr. Shraddha. Excellent talk. I'll just put in a couple of points from my side. One is that, haptoglobulin drop may not be there because haptoglobulin is a acute phase reactant, and during the distinction, should not base it anyway. Haptoglobulin is not freely available, nor do we ever use it. The other is that, if you look at the CBC and you find macrocytosis in the range of 150, 160, that will clinch the diagnosis that this is autoimmune hemolytic anemia. The reason is that if 2 or 3 RBCs clump together, as happens with IgM antibody, then they will be counted as one RBC, and from the CBC itself, you will come to know that you are dealing with autoimmune. Because this kind of a macrocytosis is not seen with B12 or folic acid deficiency, is seen only in autoimmune hemolysis. Anything above 150, take it for granted that this is a autoimmune hemolytic anemia. The other thing which is very important, as Dr. Shraddha has said, and I would like to reiterate it, is that your diagnosis or your wish to treat with a transfusion is not dependent only on numbers. What matters is the condition of the patient, and if your patient has had a sudden acute fall of hemoglobin, even if the hemoglobin is 7 and is having air hunger or is having difficulty in breathing, then you have to take care of it. And don't forget that Mycoplasma pneumoniae, which can cause pneumonia, along with even a milder or a moderate fall in hemoglobin, can exacerbate the respiratory difficulty, and that's the key. Also, please do not rush in and try to push in the transfusion, because sometimes you may tip the balance over towards decompensation, because the patients are already decompensated and you may push the balance over. I think these are the few points which I would like to say. And for all practical purposes, for a general pediatrician, I think steroids and IVIG are the things which they ought to use and may use, and anything beyond that should be left to the expertise of a pediatric hematologist or a unit which is used to handling these patients. For example, rituximab, etc., should not be used by a general pediatrician. It should be used more by a center where they are used to taking care of these patients. I think with this, I'll open the discussion. Do we have the question hour now, or do we?
No, sir, at the end. We'll be taking at the end, sir.
Okay. I think we move on to the next presentation. Is it Siddharth now who's to come in?
Yes, Dr. Siddharth, please share your presentation.
चलो विराट कोहली जी आइए, आप सेकंड डाउन, 1 डाउन पर आइए, चलिए करिए उसे.
Hello, good afternoon. Are my slides visible? Am I audible?
Yes, please go ahead.
Yes, they are.
Good afternoon. Thank you, DIAP platform, for this wonderful opportunity. Thank you, Dr. Kinjardekar, Dr. Mohiti, and Dr. Trivedi. It is indeed an honor and privilege to be talking with the mentor who is none other than the founding father of PHO specialty in the country, Dr. Anupam sir. And it also gives me great joy that the person who taught me pediatrics for the first time is there in this panel, Dr. Srinivasan, who was my HOD in JIPPER when I did my undergraduation. So over the next 15 to 20 minutes, I'm going to take you through updates in thalassemia. We all know that thalassemia is an ocean, and it would not do justice to cover the entire topic in 15 minutes or even half an hour. So what I'm going to concentrate on is to reiterate what we already know about thalassemia, which remains relevant in 2023, and what are the new modalities which have emerged in the management of this hematological disease. So we all know that thalassemia is an autosomal recessive hemoglobinopathy. There is a defect in the manufacturing of the beta globin chains in thalassemia or the alpha globin chains. Now, in our country, when we talk about symptomatic thalassemia, beta thalassemia is much more common than alpha thalassemia. So I'm going to restrict my talk to beta thalassemia today. Still, 10,000 to 12,000 children with thalassemia are being born in our country, and some people call our country as a thalassemia capital of the world. And it requires around 2 million units of red blood cells to transfuse all the thalassemics in the country every year. And we know that for transfusion-dependent thalassemia, the pillars of management is periodic adequate transfusion with compliant optimal chelation for the iron overload. This is easier said than done. If it is possible, it gives a good quality of life for children. We know that this kind of care is more accessible for people living in the urban areas compared to the rural areas. And once childhood gets over and a thalassemic goes into adolescence, teenage, and when they become young adults, they face a lot of problems and they require multidisciplinary care. And when we talk about the current curative treatment, which is available in the form of allogeneic stem cell transplant, less than 500 transplants for thalassemias are being done per year in the country, which when you compare to the number of children who are being born every year shows that there is still an inadequacy in the management of this condition. So the first thing I want to say is, traditionally, we have been taught to call thalassemia major, thalassemia intermediate, and thalassemia minor. So these are quite dramatic terms. We used to be said that if a child is presenting very early, let us say in the second 6 months of life, with huge liver and spleen requiring multiple transfusions almost every month, that would be a thalassemia major. Whereas a child presenting later after 2 years of age with a smaller liver spleen size would be an intermediate. And we also used to use HbF levels, like something more than 90% would be major and less than that would be intermediate. But now this kind of terminology is going away. Rather, what is more useful when you're sitting in the OPD is to call it as transfusion-dependent thalassemia. If the patient requires regular transfusions for life sustenance, and one would determine if the child requires transfusion based on whether there is significant anemia, like a HB falling to less than 2 weeks apart, symptomatic anemia, when there is a growth failure due to anemia, and when there is significant extramedullary hematopoiesis in the form of huge hepatosplenomegaly because of the anemia. And on the other hand, if the child is not requiring periodic transfusions for sustaining life, rather he is only requiring occasional intermittent transfusions and otherwise growing well and not having too big of a liver and spleen and having a good quality of life, then that would be a non-transfusion dependent thalassemia. Finally, compared to this, transition and non-transition dependent thalassemias were actually homozygous for the thalassemia mutations. You have the thalassemia trait or your thalassemia minor. These individuals are heterozygous for the mutation, and they will usually be picked up only based on laboratory tests. They do not require any clinical intervention, and they can actually have all iron-containing foods. I'm reiterating this because as pediatricians, you might actually come across children with a diagnostic report of a thalassemia trait. And we as hematologists often get referrals of patients who have been scared by people who have seen them somewhere in the peripheral clinics and told them that they have thalassemia and they need to stop eating spinach and all iron-containing foods. They should not take non-vegetarian food and so on and so forth. So if it is a thalassemia trait, they are heterozygous. We do not need to intervene clinically. They can eat everything. So coming to diagnosis of thalassemia, the first thing on the left-hand side, I again want to reiterate about thalassemia traits. As pediatricians, we have a unique opportunity to diagnose the trait. So when you say complete blood count for a child, done for any reason, whether hematological or non-hematological, if there is a very moderate to, very mild anemia, I would say like 9 to 10 hemoglobin, and the MCV is low, try to calculate a Menser index, do a MCV by RBC count ratio. And if that is less than 13, then it is very likely that this child might be a thalassemia trait. then you go ahead and do a HB variant analysis, and in that the HbA2 is more than 4%, then this child is a thalassemia trait. It is important to counsel the parents that when this child grows up, then and he or she is of marriageable age, rather than matching the kundli with the future spouse, we should match also the thalassemia trait status, and this can help to prevent the birth of thalassemic. So this we should remember as pediatricians when sitting in the OPD and seeing complete blood counts. On the other hand, on the right hand side, when we talk about symptomatic thalassemia, children who are coming to us with anemia, with hepatosplenomegaly, then again in the complete blood count, you're going to look for microcytic hypochromic anemia. Peripheral smear will show target cells, you all know. One very important thing is often the WBC count will be spuriously elevated because of nucleated blood cells. So always get a peripheral smear seen by an expert hematologist who can tell you there are nucleated red blood cells, because we have seen children with very high counts in thalassemia, 70,000, 80,000, it's because of NRBCs, and they undergo bone marrow thinking they're leukemia, when they could, all you need to do is a simple HB variant analysis. So look out for NRBCs and spurious leukocytosis. Then we should get a pre-transfusion HPLC or a HB electrophoresis done, which will show very high HbF levels. Important to take pre-transfusion samples. So whenever you are clinically suspecting thalassemia, please try to get a pre-transfusion sample for the HB variant analysis, because once they are transfused, you have to wait ideally for 2 to 3 months. But if they are requiring transfusions very often, at least wait till the next transfusion and do a sample just prior to the transfusion. And once you confirm with the HB variant, then we can manage as a thalassemia patient. If you are not able to get a pre-transfusion sample, or the family is expecting the next child and you want an antenatal diagnosis, then you have to go ahead and do a genetic diagnosis, for which we have a PCR based or reverse dot plot based analysis for the common mutations present in the country. If that is not able to detect the mutation, you can go for a sequencing. This again I'm reiterating because nowadays NGS is so freely available. People are getting NGS done at the drop of a hat. But please, for thalassemia, if your HB variant is a list of thalassemia, first go for a simple arms PCR reverse dot plot test, which will be able to give you the mutational result in more than 90% of the children. Then coming to the current paradigm, let us take up transfusion-dependent thalassemia. So the two main pillars, like I already told you, is transfusion and iron chelation. So for transfusion, remember we have to do an extended, or it's not enough to just say A positive, B positive. At least you have to also test for the KEL antigen status. And before every transfusion, you should test for presence of antibodies. Because if these patients are not tested properly for extended RBC antigens and antibodies, they will develop a problem called alloimmunization. So they will require more and more blood transfusions. And tomorrow, if this family wants to go for a curative treatment like transplant, this alloimmunization is going to cause a lot of problem. And remember, it is important to leukodeplete the blood again to avoid this alloimmunization. If your blood bank has leukodepletion, well and good. But if it doesn't have, please use a leukocyte filter to transfuse these patients. A picture of a filter is given in the right-hand corner of my slide. And that it doesn't cost much, and it really helps the patient to avoid this dreaded complication of alloimmunization. And transfusions are given every 2 to 4 weeks. The target pre-transfusion hemoglobin of 9 to 10.5. Again, a common error. We have children coming to us saying that when they go with a hemoglobin of 9 or 10, I'm talking about the transfusion-dependent patients. They are sent back home saying that they should come back when the HB drops like to 6 and 7. That is wrong. We want to maintain the pre-transfusion level of 9 to 10.5 so that they can grow adequately and the liver and spleen size will remain under control. And please encourage your transfusion-dependent thalassemics to maintain a diary where they will write the date of transfusion, volume, and any side effects, because it really helps us to know how much transfusions they're getting in the whole year and whether anything needs to be adjusted. And folate supplementation to be given to each and every individual thalassemia. Then iron chelation is very important. As we know, the human body is not prepared to actually excrete excess of iron. So when you're getting transfused every month, you're going to have an iron overload. This is measured with serum ferritin, easily available, and it can be done 3 monthly, and the trend can be seen. We want to target less than 1000 serum ferritin. And nowadays we have a T2 star MRI. So this is a radiological modality which can be done and which gives us an idea of the end organ damage due to the iron overload. So the main end organs which are importantly involved are the heart and the liver. So when the cardiac T2 star value is more than 20 milliseconds, it means that you're on the right track. And the liver iron concentration, previously we were doing biopsies Nowadays, it is very tedious to do. We no longer do liver biopsies. The MRI itself can give us an idea of the liver iron concentration based on an R2 technique, and that should be maintained between 3 to 7 milligram per gram. And what are the chelators available with us? It is the same chelators which have been there for more than 10 years with us. They are desferrioxamine, deferriprone, and deferasirox, which I'll talk about in the next slide. And finally, as part of the paradigm for transfusion-dependent thalassemia, we have allogenic transplant. I deliberately put a mask to it while talking about transfusion chelation. This is because without ensuring optimal transfusion, optimal chelation, one should not talk about treatments like allogenic transplant, because unless you transfuse your child properly and chelate them properly, they're not going to do well when you go for these modalities like transplant. So with transplant, with a matched donor, we're able to get a 90% survival. We have to do the transplant early. They say before 7 years of age and before the liver size, starts increasing in size. And although one is deterred thinking that this is a very costly treatment, when you actually compare it with the cost of a lifelong transfusion, chelations, and managing complications of iron overload, it might be cost effective in the long term. But the dreaded problem with allogenic transplant is when you develop a complication called graft versus host disease, which can severely impair the quality of life of a individual with thalassemia. Now, coming with the chelating drugs that we have. So the time-tested gold standard drug which is there is desferrioxamine. Unfortunately, this is a parenteral drug which has to be taken subcutaneously with a pump for several hours a day, and it can cause a lot of side effects also. It can affect the eyes, hearing, and so on. So we don't use it very commonly because the compliance would be bad with this. The oral drugs which are more commonly used in practice are deferriprone, which is given thrice daily, but one has to closely monitor the complete blood counts because it can cause agranulocytosis and neutropenia, and can also cause some musculoskeletal pains like an arthropathy. The most popular drug nowadays, the most commonly used drug nowadays for ankylation is deferasirox, given at a dose of 20 to 40 mg per kg per day once a day. Some people use it twice a day, but recommended is once a day. And it can cause increase in OT, PT, creatinine, and urine protein. So we have to monitor this at least once in 1 or 2 months. And this is what is commonly used because the compliance is best with it. And while on chelation, we target ferritin between 1000 to 2500, liver iron concentration between 3 to 7 mg per gram, and a T2 star MRI, T2 star more than 20 milliseconds. Then you know you're on the right track. If the ferritin is higher than 2500 or the cardiac T2 star is falling below 20 milliseconds, it means that you need to intensify your chelation therapy or maybe add another drug also. Then, of course, we have to talk about long-term complications. We know that there are a lot of organs which are going to be involved with time. So first, starting with the heart. So usually by 8 to 10 years of age, thalassemia children will develop heart complications. You have to do annual ECG and echo. And T2 star MRI, that's why it is good to do after 7 to 8 years. There is no point in doing T2 star MRIs in a 3-year-old or a 4-year-old. So please start doing T2 star MRI if you have access to it after the child is around 8 to 10 years. And if there is evidence of cardiac disease, you have to intensify chelation. Desferrioxamine is probably the only drug which can help if a patient has a symptomatic cardiac disease due to iron overload. Then coming to liver, one simple thing is you have to ensure hepatitis B vaccination for all children with thalassemia. And we should also do regular viral serology screening. Even if the child is hepatitis C positive, now we have very good antivirals to treat it, which can actually clear the viral load if the child has hepatitis C. And if the patient has biochemical evidence of liver disease, then we should do ultrasound abdomen once or twice a year because they are predisposed to hepatocellular carcinoma, which will become a complication of the liver fibrosis due to the liver disease. Then the various endocrine organs in our body can be involved by the iron overload. So most importantly, we should see the weight and height every time we see a thalassemia child in the OPD. We should also test for thyroid function test after 9 years. Look at the sexual maturity after 10 years. And if there is evidence of hypogonadism or a failure of menarche or development of sexual characteristics in the children, we have to evaluate for the hormonal profile. And also parathyroid hormone levels we should do after 16 years of age. Then bone health is also very important. When you're seeing a thalassemia child, we should monitor calcium phosphate treatment levels, supplement whatever is deficient, and look for osteoporosis with DEXA scans. And if there is severe osteoporosis, they can benefit with drugs like bisphosphonates. Now, coming to non-transfusion dependent thalassemia. So again, previously they used to be called intermedia. It seems to falsely imply that they have, lesser complications than thalassemia major, but that is not true. Non-transfusion dependent thalassemia, or previously called thalassemia intermedia, is actually a very unique disease. each patient actually behaves in a different manner and needs a very individualized approach to treatment. So if you see, there are two components again, like in the previous transfusion dependent therapy, you have the anemia and the iron overload. Now, if you see the anemia, especially if the HB is less than 10, or if the HB is okay, but you're anticipating complications, then we need to intervene for the anemia. So the options that we currently have are either you can have intermittent blood transfusions. For example, if the child is failing growth, you might want to give some transfusions for 6 months to 1 year till the growth actually catches up with the peer. The other option we have is hydroxyurea, which is very commonly used and shown by many studies to be effective in thalassemia intermedia. So you can start at 10 to 15 mg per kg per day, very well tolerated drug. And in most patients with thalassemia intermedia is able to maintain a hemoglobin of around 7 to 9 gram per deciliter in them and give a good quality of life. Luspatercept we'll talk about later. It is not approved in less than 18 years children. So we have now transfusion, which is a very good drug for these patients. These patients can have a lot of unique problems. In addition to what the thalassemia major patients have, like growth failure and extramedullary hematopoiesis, osteoporosis, and endocrinopathies, these patients can also have thrombotic complications, pulmonary hypertension, leg ulcers, which we need to watch for in the OPDs. On the other hand, iron overload. Even if a patient is not transfusion dependent, he can still be iron overloaded because thalassemic patients will have increased gastrointestinal absorption of iron. So here the iron overload will start later by around more than 10 years of age. So vis-a-vis transfusion dependent thalassemia, where you will be starting chelation by the age of 2 years. Here you might have to start chelation by the age of 10 years or above, when the ferritin goes above 800. Again, the drug of choice here is deferasirox. Okay. Now coming to the next thing, splenectomy. So as pediatricians, I think more than 10 years back, splenectomy was very popular in thalassemia. It was considered something like a poor man's treatment for thalassemia patients, particularly when they needed a lot of transfusions. But now, more and more, we are moving away from splenectomy. It is no longer used routinely, either in transfusion dependent or non-transfusion dependent thalassemia. We now know that in addition to infection risks, which we already know, but post-splenectomy overwhelming sepsis is something we're familiar with. We now know that it can also increase risk of thrombosis, which can affect quality of life and be life-threatening also. It is not relevant if a patient is on regular transfusion and is optimally chelated and having good quality of life. We should only do it if the transfusion requirement is more than 200 ml per kg per year with the inability to chelate effectively, or the patient is having troublesome cytopenias due to hypersplenism, or there is a massive splenomegaly, you're worried about a ruptured spleen, or it's symptomatic with early satiety and causing abdominal pain. Laparoscopic splenectomy is always preferred, and we should remember to vaccinate the children at least 2 weeks prior before the Haemophilus influenza, pneumococcus and meningococcus, and give annual flu vaccination thereafter. And very important to give them penicillin prophylaxis. And just like in oncology, when you see neutropenic patients, you tell them you have fever, you immediately come to the hospital and get antibiotics. In the same manner, you have to counsel a splenectomized child to come immediately for care if they develop fever or any infection. Now coming to what is really new, all this I think you are already will be familiar as pediatricians. I've just reiterated. Now what is new? So you know that the pathophysiology of thalassemia is there is a alpha beta chain imbalance. You have less beta chains, more of alpha chains. These alpha chains will precipitate in the erythrocyte precursors, causing the precursors to die early and lead to ineffective erythropoiesis inside the bone marrow. And there is also iron overload due to transfusions and increased gastrointestinal absorption. And there is anemia due to the ineffective erythropoiesis and also due to peripheral hemolysis of the red cells. So the curative therapy we know was matched donor transplant, but now there is a lot of alternate donor stem cell transplant which is coming up. And of course, gene therapy has come up, which can actually correct the underlying genetic defect. Then another way is you can increase the gamma chain production. So the gamma chains will then bind the excess of alpha chains and decrease this imbalance which is happening. Then there are drugs which have come which target the ineffective erythropoiesis in the form of luspatercept and mitapivat. And in regards to iron overload, we have a new formulation of deferasirox called the film-coated tablet, and we also have hepcidin analogs which are coming up. So let's quickly see about all these modalities. So film-coated deferasirox tablet is available in the form of Oleptis manufactured by Novartis company. We have to give it at 0.7 times the dose we give the original deferasirox that we use. The advantage is the old deferasirox, it has to be taken empty stomach. Very challenging for children going to school to take it before breakfast and get ready for school. So this can actually be even sprinkled on soft foods like yogurt or taken with a light meal. And therefore the compliance will be better and it has less adverse events. Only problem is the cost, but hopefully in the future the cost will come down. More and more it is used. Now coming to allogenic transplant, right now the recommendation is to do it for all young children who have a matched donor, in which case the mortality is very less. And especially in India, because this is a curative modality, we should encourage HLA testing. And because it is consanguinity, marriage within the community, there is a chance that even the mother or father or rarely even an uncle or aunt might be a completely matched donor. So we should support a child to get HLA match with the siblings and the mother and father as a bare minimum, so that if it is there, we can support the child for an allogenic transplant. And a lot of complications are being managed better. For example, we used to face hepatic VOD with a drug called busulfan. Now we have triosulfan, which decreases this risk. And now there are registries which have match unrelated donor volunteers. So healthy individuals who come up and say that if my HLA is matched with a patient, I will come forward and donate my stem cells. So even with match unrelated donor transplant, we are getting now up to 80% survival. And very interesting, now haploidentical transplant, you need not be fully matched and still patient can undergo transplant. And any patient will have at least 2 haploidentical donors in the form of the mother and the father, who will be very motivated donors for the transplant, and techniques like T-cell depletion, post-transplant sacrifice have made this possible. So, and now we have schemes, government schemes, and the Coal India project is actually supporting transplants for happening in these patients. Then coming to luspatercept. So just to explain how this drug works, on the right hand side you can see the picture. So basically there is a family called as TGF beta signaling family of ligands, which will influence the erythropoiesis. So what this drug luspatercept does is, it will go and trap the TGF beta ligand so that it is not available to interact with the receptor on the cell surface of the erythroid precursors. So this allows the erythropoiesis to be activated, and compared to thalassemia where the erythropoiesis is ineffective, this luspatercept allows the erythropoiesis to actually increase and compensate for the anemia in thalassemia. So the drug is given subcutaneously 3 weekly. There are trials in transfusion dependent and non-transfusion dependent thalassemia in adults who are more than 18 years old, where it has been shown to be effective and decreases the transfusion requirement and improves the hemoglobin. The adverse events are very much tolerable in the form of bone joint pains and hypertension, hyperuricemia, and so on. So trials are underway in children, and soon hopefully it will come to children also. Then coming to gene therapy, very interesting modality, much talked about. The advantage is you don't need a donor like in thalassemia, and you're not worried about the dreaded complication of graft versus host disease. So already phase 3 studies have showed up to 90% patients can become transplant free with gene therapy, and children have also been included in these trials. Long-term follow-up studies have also shown that up to 2/3 to 90% of patients are transition free after gene therapy. But there are again concerns. Again, how do you do a gene therapy? On the right-hand side, you can see the flowchart. You are going to collect stem cells from the patients with thalassemia by giving them drugs like GCSF. And then these collected stem cells are going to transduce with lentiviral vector, which will code for the normal hemoglobin A gene. And then these transduced cells will be given back to the patient after the patient is myeloablated with high-dose chemotherapy. So again, here you're going to have problems like toxicity with chemotherapy. You're using viral vectors. You're worried about mutagenesis. And then you need vascular access, stem cell collections, all these complicated procedures, which is quite resource intensive and costly. And now it is still not available in India, but hopefully in the next 10 years, it should come to our country also and benefit our patients. Then finally coming to what are the other interesting therapies which are coming up, you have gene editing using enzymes like CRISPR or ZN, which will actually induce deletions in the BC11A gene, which actually shuts off the HbF production. You know that after 6 months alone, the hemoglobin F stops being produced and the hemoglobin adult one starts to be produced. So this will help to continue HbF production and therefore maintain the hemoglobin levels. We also have drugs like ruxolitinib, JAK2 inhibitor, which can actually decrease splenomegaly and improve erythropoiesis. Mitapivat, which is actually being used in pyruvate kinase deficiency, but has also been shown to be effective in thalassemia patients in some studies by enhancing erythropoiesis. And we also have this hepcidin agonist. So hepcidin is actually like a policeman of iron. It prevents iron from accumulating in the body. So by agonizing hepcidin by inhibitory RNA and hepcidin analogs, we can actually decrease the iron overload and improve erythropoiesis. But these are all under trials, not really come into clinical practice still. So with that, I come to the end of my talk. So the take home message is, sir, please try to pick up thalassemia traits when you see your complete blood counts in the OPD and in your ward rounds. And you can play your part as pediatricians to prevent thalassemics. Because if you counsel the parents, they will never forget. They will ensure that when the child grows up, the spouse will be screened for thalassemia trait. And always facilitate antenatal diagnosis when the parents plan the next child by getting a genetic diagnosis in the index patient. Optimal transition chelation are imperative even now. Even if the family is planning for transplant, you need to do this till the child goes for the transplant. And we have to individualize therapy for patients with non-transfusion dependent thalassemia. And it is good to start hydroxyurea trial for children with anemia. And once they are older, they will also need chelation. And we should try to support HLA matching for all families who are transition dependent or severe non-transition dependent thalassemia. And even haploidentical transplant has come up as an option. And if the family is able to reach a center with experience, that can be offered as an option. Luspatercept is emerging as a useful drug, but it is not yet approved for children. Gene therapy is an attractive therapy, and we hope it will come soon to India. Thank you very much.
Thank you very much, Siddharth, for the extensive and intensive review of thalassemia. Couple of points which we have to consider, and some. Can I ask you? One of the people also wants to know. You have not talked about the role of thalidomide in patients of thalassemia. Would you like to say a couple of lines on that? Because that's quite a bit in the news, both as with the patients as well as the doctor.
Yes, sir. That's a very important question, sir. Actually, I left it out because it is become like a controversial area. Thalidomide is a drug which acts by increasing the HPF production. So it has been, there have been multiple studies done both abroad as well as in India. So in India, we have a good paper from Jagdish Chandra sir, who has shown prospectively that thalidomide actually improves hemoglobin, and a significant proportion of patients, more than 50% of patients, can become transfusion free with the use of thalidomide. But the biggest problem with thalidomide is the concern of the safety. There are a lot of dangerous adverse events which are reported with thalidomide. This include neurotoxicity. There have been reports of it causing neutropenia. We already know it is a teratogenic drug, and there is also concern of thrombotic complications. We have seen patients who have been on thalidomide and have landed up with complications like stroke. So yes, thalidomide is an effective drug in thalassemia, but if it has to be given to a patient, then the family has to be explained the pros and cons, and the child has to be monitored very closely for adverse events. And another thing we have seen is thalidomide works for a couple of years. The patients become thalassemia free, but then again they start requiring transfusions, and then they start exploring other modalities like transplant, which will give them a permanent cure. Sir, if you have anything else to add.
I think as far as thalidomide is concerned, it should not be used outside a clinical research protocol. That is what my thinking is, because then you will be counseling the patient, the parents also, and make sure that you are doing things properly rather than using it randomly on any patient and every patient. So that's very important. At the moment, we do not want to use this drug outside a clinical research protocol. That's my take on thalidomide. Anything, I think we'll move on to the next and take the questions at the end as suggested by Mahesh. What's the screen there? Preetham, are you there?
Yes, sir, I'm there. I'm just mounting my slides.
Yeah, thank you.
On full screen.
Yeah. Is it in the full screen mode, sir?
Yeah, please go ahead.
Good evening, everyone. Thank you so much. At the outset, I want to thank the organizers to invite me for this academic session. It is indeed a great honor to talk on this topic. Of the stalwart Dr. Sachdev here. Before I start giving my talk on sickle cell disease updates, I would rather be interested to give 2 disclaimers. Number 1 is, though it mentions update, I will barely talk about the recent updates of sickle cell disease because I thought the primary audience is going to be pediatricians and the pediatric fellows and residents. I will stick to the basics of the pathophysiology and the management perspective. So pardon me for not touching much on the recent updates. And secondly, I would give this disclaimer that I'm not really a sickle cell expert. Unfortunately, I've been trained from PGI Chandigarh, the northern part of India, where hardly there is sickle cell disease. Now I work in Eastern India, where again the bulk of sickle cell disease is less. So my personal experience, if you talk about in sickle cell disease, is quite a bit different. There is a prologue. I will talk a bit about the epidemiology, the pathogenesis, the clinical features, especially the different crises I will try to emphasize, the diagnostic aspects, and then obviously the management overview, just an outline I will touch upon. So as we all know that sickle cell disease is the commonest qualitative hemoglobinopathy across the globe. As we know, thalassemia is the most common quantitative hemoglobinopathy. Sickle cell disease is the most common qualitative hemoglobinopathy. And as we all probably know that it is a single amino acid alteration, that is the 6th position, 6th amino acid in the beta globin chain. You have a single mutation, a missense mutation, which leads to the replacement of glutamic acid by valine. And this single point mutation leads to a drastic alteration in the physicochemical properties of this beta chain, because glutamic acid is a carboxylic acid which is very much water soluble, vis-a-vis valine is a methyl group containing aliphatic amino acid which is least soluble in the aqueous environment. So this significantly leads to alteration of the physicochemical properties of hemoglobin, especially in the beta chain, that leads to precipitation of this beta chain, especially when it is in the deoxygenated state, and therefrom the whole pathophysiological cascade starts with. We'll go to that in the subsequent slides. Before that, I just want to clarify this terminology at the very outset. That what is the meaning of sickle cell disease? The term sickle cell disease is basically an umbrella term that encompasses the whole gamut of the hemoglobinopathies which has sickle component. Like let's say sickle cell trait, which is a heterozygous state for sickle cell disease, are often called the sickle cell carrier. It also includes homozygous sickle cell disease, and it also includes different compound heterozygous state in which one of your beta chain is having sickle mutation and another one is having some other mutation. For let's say sickle beta thalassemia or sickle D or sickle C, like that. So these conditions are sickle compound heterozygotic states, and all of these conditions are termed under a single umbrella term, which is sickle cell disease. Coming to the epidemiology, so the global estimated birth of homozygous sickle cell disease is approximately 112 per 100,000 live births. If you see globally, the highest burden is indeed seen in the African continent, followed in the South America. In the African continent, the prevalence can go as high as 1100 per 100,000 live births. The mortality statistics, if we see, it is 0.64 per 100 child years. And obviously the highest rate is again in the Africa, where it can go as high as 7.3 per 100 child years. Concentrating on the Indian scenario, and as we know that it is especially been concentrated around the tribal belt in the country. It is a disease predominantly of the central part of India. And as we know, there is a sickle belt which starts on the southern districts of Gujarat, and then a big chunk of Maharashtra, Chhattisgarh, Madhya Pradesh, and then it spills over into some parts of Jharkhand and even some western districts in the West Bengal also, and obviously Odisha, in which the burden is substantially high. The prevalence of the carrier state varies significantly, and different population-based data has shown that the carrier state can fluctuate between 1 to 40% depending upon different pockets of the country. Coming to the pathophysiology, which is very interesting to understand. The whole process starts from here. So as we know, here the beta hemoglobin is a tetramer composed of 2 alpha chains and 2 beta chains that forms a globin component, and then you have heme. Now here the beta globin chain is altered to form sickle beta, which has poor affinity for hemoglobin, has a poor affinity for oxygen, and also has poor water solubility. So till they are well oxygenated, these red cells are happy. But the moment they reach a situation in which there is hypoxia in the environment, or there is vascular stasis, or if there is an acidic environment, acidic microenvironment, the whole process starts. It leads to deoxygenated sickle beta chains polymerization. These sickle beta polymerizations, obviously they're insoluble. They precipitate on the red cell membrane, resulting in membrane damage. Once this membrane gets damaged, there happens opening of different stress-sensitive calcium channels. From your extracellular fluids, calcium ion influxes into the red cell cytoplasm, and that leads to opening of these calcium-sensitive potassium channels. This leads to rapid export of the potassium channels out of the cells. Whenever potassium goes out, it takes its friends along with, which is water molecules go out of the cell, resulting in progressive cellular dehydration. Dehydration leads to increasing in the concentration of the sickle cell hemoglobin inside the cell, and thus a vicious cycle gets turned in. That leads to progressive sickling of the red blood cell that now starts interacting with the vascular endothelium, resulting in local vascular microcirculatory clogging. This clogging leads to local hypoxia, acidosis, further vascular stasis, and thus a microcirculatory blockage sets in, which is only a vicious cycle as it goes. So as we can now understand, the most important precipitants of having such a sickling episode includes your hypoxia, an acidic environment, sluggish circulation. Dehydration is also an important contributor, which leads to precipitation of all these events. And probably only factor by which at the pathomechanistic level we can ameliorate all these events happening is by improving the HbF, which interferes with this polymerization of the sickle polymerization, and thus can ameliorate the microcirculatory clogging and the associated vascular damage that happens. So this is very important because most of our therapeutic armamentarium, their basic target is to interfere with this sickling polymerization, and by increasing the fetal hemoglobin proportion or percentage inside the red cell. Coming to the clinical features, so whenever we talk about the clinical manifestations of sickle cell disease, there are two facets of that. One thing is the chronic complications, because it's a state of chronic hemolysis that lead to a gamut of chronic health-related complications. And this chronic story is compounded by intermittent episodes of acute crisis, which brings them to the hospital and significantly jeopardizes their quality of life. What are these chronic complications? These are multi-organ complications, which can start from your growth retardation, little complications like avascular necrosis of the bone. It can lead to renal complications like renal medullary damage, resulting in nephrogenic diabetes insipidus. It leads to chronic neuropsychological, neurocognitive deterioration. Hyposplenism is an important complication of this that sets in from very young infancy, leads to repeated bouts of penile microcirculatory arrest, leads to sexual dysfunction. You can have cardiovascular morbidity in the form of pulmonary arterial hypertension and subsequent right heart failure, cor pulmonale, etc. Retinopathy associated with sickle cell disease. So you can see it's a gamut of injury that can happen across the organs in the body. And then their history is compounded by acute crisis, which are mostly in the forms of vaso-occlusive crisis or pain crisis. They can also have aplastic crisis, splenic sequestration crisis, etc. One important peculiarity of sickle cell disease is that splenomegaly, which is a classical teaching from our MBBS thesis, sickle cell disease is a hemolytic anemia in which you don't expect splenomegaly because of repeated microvasculatory infarcts, your spleen undergoes so-called autosplenectomy. However, in Indian continent, we know that genotype is such, their phenotype is not that severe, and often we get splenomegaly in the children and in the adolescents. So that is something unique for the Indian patients. Coming to different acute crises that we encounter. Acute chest syndrome. So acute chest syndrome is one of the most common such crises that brings these children to the hospital. So what is this? It's basically the clinical manifestations will be with new onset respiratory symptoms in the form of cough, respiratory distress, along with hypoxemia, with or without chest pain. And if you do a chest radiograph, you find there are presence of new pulmonary infiltrate. What is the pathophysiology behind this? It is basically pulmonary vaso-occlusion, often precipitated by intercurrent viral or bacterial lower respiratory tract infections. That leads to your the circulatory block, vascular clogging, resulting in infarction, which is obviously compounded by an infection. It often follows a course of high-dose opioid analgesic therapy for a previous episode of dactylitic crisis or painful crisis. How do you manage? You admit the children in the hospital. The supportive care includes supplemental oxygen, good quality chest physiotherapy, intravenous antibiotic, which must include coverage for pneumococcus as well as mycoplasma. The ceftriaxone and azithromycin is the typical antimicrobial combination which has been preferred, and you have to basically reduce the HBS proportion to less than 40% or less than 50% in order to abort an episode of acute chest syndrome. So exchange transfusion, single volume or even sometimes double volume exchange transfusion is something which can terminate an episode of acute chest syndrome. Another vaso-occlusive crisis is dactylitis. As this picture shows, it presents with acute painful swelling of the hands and the feet. This is again the pathophysiology is vaso-occlusion, bone infarction, and the precipitants typically include cold weather, dehydration, hypoxia. Management is generally supportive with analgesics and hydration. However, despite these conservative measures, symptomatic improvement fails to happen. Exchange transfusion is something which is often required. How to do laboratory diagnosis in the suspected case of sickle cell disease? Obviously, the first step in evaluation would definitely include a complete blood count with peripheral smear examination. And in peripheral smear, you might find such sickle cell RBCs. At community level, there are some screening tests in practice. Two of them most commonly been used, the sickle solubility test and sickling slide test. The sickle solubility test is based on the principle that in a hemolyzed sample, after you have hemolyzed the RBCs with some buffer solution, if you add a reducing substance, something like a sodium metabisulfite, the reduced sickle hemoglobin, as I've said, they are not water soluble, that lead to formation of hemattic liquid crystals, and that make the solution turbid. As you can see, you cannot read these black lines across. So that gives you a positive sickle solubility test. This sickling slide test is basically on a slide you put unstained blood drop, you cover that with cover slip. You put sodium metabisulfite and then you cover with the cover slip, and from all the sides you close it with paraffin to make a kind of hypoxic environment. And then you examine under microscope that in an hypoxic or anoxic environment, there is formation of such sickles when you incubate the red cells with sodium metabisulfite. But mind you, both of these tests are basically screening tests. They're not diagnostic. The diagnostic or the confirmatory test is only by doing hemoglobin variant analysis, by performing high performance liquid chromatography. And that's kind of the chromatogram that you get in a patient with homozygous sickle cell disease. You find a slow moving band which forms a peak at a retention time of around 4 to 4.5 seconds. That's a diagnostic HPLC finding in a patient with sickle cell disease. I'm not going in details into the other forms of sickle cell disease like HBS beta, HBS heterozygous state, how the HPLC findings are. Whoever is interested can go through. There are nice articles available. Coming to the management. Now, management of sickle cell disease is something which we can talk, talk for hours altogether. I will just, with this limited scope of time, try to discuss on just an outline of the management. And I would like to discuss on the two different aspects. How do we manage the crisis and what is the plan of long-term management? Pardon me. So management of the vaso-occlusive crisis. What are the goals of management of vaso-occlusive crisis? Basically a fast pain control and prevention of the tissue damage from the ischemic injury. The supportive care obviously includes antibiotics, like for acute chest syndrome we have mentioned, hydration. As we have said, that dehydration is one of the most common precipitant of vaso-occlusive crisis in children. Adequate hydration is something which is critical. Analgesia. Analgesia should always be optimal, and one should be using a step-down approach rather than step-up approach for analgesia. It is often common to under-treat pain. However, that's never the ideal way of managing pain in sickle cell disease. One has to be liberal in the use of opioid analgesics like morphine, methadone, along with NSAIDs, achieve adequate pain control. Patient control analgesia is something which again is very pivotal in managing the pain adequately in sickle cell crisis. And as I say, to abort an episode of vaso-occlusive crisis, drastically you have to reduce the sickle hemoglobin concentration to 40 or 50% or less. So for that, an effective way of managing will be simple or exchange transfusion. I have not included a slide, but I probably should have. That's management of priapism. We don't see that very commonly in children, but obviously in adolescents and young adults, we can see that. Management of priapism generally includes supportive care initially in the forms of hydration, adequate pain control, getting a warm bath often can abort a minor, non-severe episode of priapism. However, if it's not been able to control, then we shouldn't waste time. One should take help of a surgeon to do a cavernosotomy to drain out the engorged corpora cavernosa. Sometimes intracavernosal injection of alpha agonists like phenylephrine or adrenaline, etc., can also help in aborting an episode of penile priapism crisis. Coming to the outline of the long-term management. So long-term management, if you have to discuss, there are certain areas: penicillin prophylaxis, hydroxyurea, chronic transfusion, and immunization. These are the different 4 domains in which I would like to discuss. Coming to the penicillin prophylaxis. So why are we talking about penicillin prophylaxis? So as we all know that functional asplenia or hyposplenia is one inevitable complication of sickle cell disease. And now we know that there is colossal amount of evidence that from infancy itself, this hyposplenia actually sets in. And that's why all these children are practically asplenic, and they are at the risk of overwhelming post-penectomy infection, especially due to encapsulated organisms. So pneumococcus being one of the most dreadful of them, it is our responsibility to adhere to all sorts of measures in which we can prevent a pneumococcal infection. And penicillin prophylaxis has been very pivotal in preventing the infection-related mortality. This information we know from long back from 1986, where this randomized trial, PROPS trial, have shown that with simple intervention like oral daily penicillin prophylaxis, 85% reduction in the infection risk happened, and there is also drastic reduction in the infection-related mortality. So it is a single most useful intervention that can significantly reduce the infection-related morbidity and mortality in patients with sickle cell disease. So phenoxypenicillin, penicillin B, or the oral methoxypenicillin, is been something which is used, and these are the dosing based on the ages, based on the age. So that is something we have to always use. Vaccination. So again, because they're hyposplenic, we should protect them from all the encapsulated bugs. So pneumococcus, meningococcus, Haemophilus influenzae, enteric fever, and annual influenza. Enteric fever is especially common for low middle income countries setting like us, will not be that significant for the Western countries, and annual influenza. So this group of this vaccination we should ensure in any child with sickle cell disease. Coming to hydroxyurea. So hydroxyurea is basically an agent which is hydroxycarbamide. It basically induces fetal hemoglobin synthesis. And if you remember my first slide on pathophysiology, as I said, that a single factor which can ameliorate significantly that of the pathophysiologic cascade of sickle cell disease is an elevation of the HbF. If we can increase HbF, that HbF will interfere with the polymerization of the sickle HbS hemoglobins, and thus can stop or at least ameliorate or curtail down the severity of the sickle episodes. However, now we know that this is probably not the only mechanism. Hydroxyurea has multifaceted mechanisms of reducing the severity of disease in sickle cell disease by alteration of the nitric oxide metabolisms, reducing inflammation, and so on. So the clinical benefits of hydroxyurea get translated to reducing the burden of dactylitis crisis and pain in general, It reduces the risk of stroke and the cerebral vasculopathy, reduces the frequency of acute test syndrome, need of blood transfusion, need of hospitalization, and all of them eventually translates to an improvement in the quality of life. Achievement of a fit HbF proportion of more than 20% with the use of hydroxyurea is associated with a drastically reduced risk of hospitalization. And hydroxyurea is very safe. The landmark paper Baby Hug trial have shown that hydroxyurea is safe in infants as young as 6 months of age. Typically, the starting dose is 10 milligram per kg, and one can hike by 5 to 10 mg per kg to achieve a maximum dose of 35 milligram per kg. Myelosuppression, the neutropenia is the most feared complication. However, severe neutropenia or neutropenic sepsis or mortality, etc., are exceedingly rare. So it is very safe drug to use. Sometimes it can cause skin, nail changes, etc., easily manageable. Indications of chronic transfusion. So sickle cell disease is not something that requires chronic transfusion, but there are some selected clinical indications in which one patient has to be put on chronic transfusion in order to prevent chronic morbidities. And those are that following an episode of acute ischemic stroke, one should use chronic transfusion regimen. One should put a patient on chronic transfusion regimen to prevent an episode of second ischemic stroke. In patients with cerebral vasculopathy, so every sickle cell center uses a monitoring tool for assessing the cerebral vasculopathy, which is called transcranial Doppler velocimetry. If you have an abnormal TAM or TMX value, which indicates that there is cerebral vasculopathy in evolution, these patients are at the high risk of developing stroke, and they should ideally be put on a chronic transfusion regimen to reverse the cerebral vasculopathy and prevent an episode of stroke. If a patient has repeated episodes of acute test syndrome requiring hospitalization, or a patient has already developed pulmonary arterial hypertension, these are the situations in which one patient should be put on a chronic transfusion regimen. But obviously, the risk of transfusion-transmitted infection and iron overload remains. As this was the class on update on this, I just will be taking 2 more minutes to give you newer updates. So 3 new drugs, not very new now. They have entered into the armamentarium for a few years now. So these agents are now crizanlizumab, voxelotor, and glutamine. All of these drugs are now FDA approved. Just a few words on crizanlizumab. So as the name suggests, it is obviously a humanized monoclonal antibody against P-selectin. Now, why P-selectin? So P-selectin is basically the cell addition molecule expressed on the surface of the leukocytes. Now, why are you talking about this? Sickle cell disease is basically an inflammatory process. After the sickling happens, the sickled RBC starts interacting with the endothelial cells and sets in a process of inflammation. So if we can somehow block one of these intercellular communications, then we can significantly alter this process of inflammation and the microvascular injury. That's the basic pathophysiologic understanding. So based on that, the crizanlizumab was designed, and the paper which came out 5-6 years back in NEJM, the pivotal, the path-breaking sustained trial, found that with the use of the crizanlizumab, there are different dose regimens. With the crizanlizumab, when they compared with placebo, the annual rate of the pain crisis requiring hospitalization significantly improved, and obviously that translated into improvement in the quality of life. However, as of now, so the drug has been approved for adults as well as for adolescents 16 years and older in 2019 November. However, the cost has been so much quite exorbitant and prohibitive. Other agents are voxelotor, which is an agent which interferes with sickled hemoglobin polymerization, and L-glutamine is something which has some effect on nitric oxide metabolism and NADPH oxidase and thus leads to vasodilatory properties. So crizanlizumab is a good drug that will significantly improve the quality of life of these children. To start with a dose of around 5 mg per kg. Initially, there are the initial loading doses are given at 2 weeks interval, 2 doses, and then you repeat every 4 weekly. So each vial would cost approximately 40,000. So that is quite prohibitively costly, but we expect in the upcoming years probably the cost will come down. With this, I will end my talk. So the take-home messages are perhaps that sickle cell is the commonest qualitative hemoglobinopathy. The burden is quite substantial in the central part of India, in the tribal communities. The natural history has 2 components, a chronic hemolysis and microvascular damage, compounded by episodic episodes of crisis like acute test syndrome, dactylitis crisis, priapism, splenic sequestration crisis, etc. Hydroxyurea is economic and safe. It significantly cuts down the need of hospitalization and improves the quality of life. Hyposplenia is quite inevitable with sickle cell disease. Penicillin prophylaxis and vaccination against encapsulated bugs is quite important. There are a handful of newer molecules in the horizon, but as of now, they're not in access to our routine clinics financially. This was a mentor-mentee session, so I think I can't finish my talk without expressing my gratitude to my mentors, Professor Amita Trehan, Dr. Deepak Bansal, Dr. Dicha Jain, and my previous speaker, Dr. Siddharth himself was my mentor. So I'm thankful to all of them, to whatever hematology I understand today is because of them. And this is a beautiful hospital where I currently work. Thank you so much. I hope I have completed within my time.
Thank you very much for the excellent talk. Now, I would like to add on a couple of things to this thing. First of all is that the government of India has announced a sickle cell disease project for screening 7 crore people for the next 4 years. And it has been allocated a budget of 2,000 crores for this purpose. Okay. Now, next point is that there are now quite a few what we call as point of care tests, which can be used and with a good sensitivity and specificity. And these are slide-based tests. One is a sickle scan sickle scan test, which gives you, just like in a pregnancy test, it will give you whether your patient has sickle cell disease, has sickle cell trait. And then there's a hemotype SC test, which is also similarly a slide-based test. And the third one, which is available, is actually a small instrument which is battery operated, which is electrophoresis machine, battery operated, and it will also give you everything in a jiffy. And these tests can be done in the periphery, in the community. So these are the 3 new tests which have been added as into the armamentarium of the point of care test. Another point which I would like to point out is that in sickle cell in India, there is a component that HbF can be high even in sicklers, and there are the Indian thing is having a high HbF, so we can actually benefit our patients much more if we give hydroxyurea than the patients in the African continent. The third point which I would like to bring out is the role of hematopoietic stem cell transplantation in a patient of sickle cell disease. There are now guidelines available for specific conditions in which hematopoietic stem cell transplant can be done. And we hope that in due course of time, the Coal India project with the Bal Thalassemia Swasth program, in that the sickle cell disease will also be included as a part of that program, so you can get funding for your sickle cell patients. Another point which I would like to bring out is that in sickle cell disease patients, it's very important to keep hydration. Hydration should be excellent. So in the schools and in in colleges, they should be allowed to drink water ad lib. And then not only that, as I say, when you drink ad lib, you have to go for urination also. So they should be allowed to go for urination 2, 3, 4 times during the schooling, because that is where teachers tend to say, oh, this child is malingering and does not allow them to go for urination. And the other issue is that even sickle cell trait patients or sickle cell disease patients should not go to higher mountains and should be careful when they are flying, even in the aeroplane, because they can present with a crisis during that period. So these are some of the small little things which I have added. Now, coming to the questions in the in the chat box. I think Siddharth has left, but his questions were: do we need to do antibody testing for hepatitis B and C? Absolutely. In fact, when a new patient of thalassemia or sickle cell comes, we should have an initial screen for Hep B, Hep C, and we should have a yearly screen of Hep B and Hep C in these patients. The other point which was asked, let me see. Another question which was asked was, I think, for Shraddha, and that is on DCT negative AIHA in pediatrics is a rare entity. Yes, we know all that, but it is still an important area in which you need to look at. Thalidomide in thalassemia has been answered. Any role for dapsone in increasing HbF? No, I don't think at the moment we can use that for increasing the HbF. Now, for the audience, if you have any questions, please send them to us so that we can take care of them. Anything else you'd like to add?
Yeah, we want to ask few questions from our end as well. So maybe to Shraddha. Shraddha, you said about the cold antibody mediated hemolysis. But quite often we see this patient who is exposed to cold, and then after even bringing back to normal temperature, he keeps hemolyzing. So as you said, hemolysis will be at 4 degrees or something. But even if getting back to normal temperature, they keep hemolyzing. What is the mechanism of this? If it is cold antibody mediated, it should be hemolyzing only at that low, right? Why it should continue even beyond that?
Yeah, sir, because the cold antibody, there is the cold antibodies, what happens, the IgM type of antibody, they get attached to the RBC at the peripheral circulation where temperature is low. And that combination, the IgM and RBC, they activate the complement pathway, the classical complement pathway. In that process, the complement C3b, actually C3d is also there, C3g is also there, but main role of C3b is there. So that get attached to this complex. So there is a complex of IgM, RBC and C3b. So those three are in the line. Now, when this RBC is circulating and it goes into the core part or a warmer circulation, during this warm thing, the IgM releases, but C3b doesn't release. C3b keeps attached to this RBC. Now, since C3b is attached to the RBC, these are the complement mediated lysis, which is seen in the cold agglutinin. And that's why these RBCs, they are taken by liver macrophages or the Kupffer cells, that is called. So even if we do the temperature normalizes, this complement mediated complement is responsible for this lysis.
Can I also add? Sorry, am I audible?
Yes, sir. Yes, sir. Please go ahead.
Yes, sure.
Can I also add that, I'll give you an example. You infuse 5 ml of unmatched blood in a patient. Now, logically thinking 5 ml will lead to only that much of hemolysis. But once the hemolysis is triggered off, then it may be difficult to stop it. So once the trigger is there, it goes on and it can go on rampantly. Even if you remove the cold bit, it may still continue because of the triggering of the system. As he said, the trigger, I'm not going to pathophysiology in a great detail, but once it is triggered off, it can go on rampantly. So that is very important to understand.
One more thing is you talked about the cardiac MRI in a thalassemia. How early you want the patient to be monitored for cardiac MRI T2 images? How early it should be started?
Well, strictly speaking, the heart iron starts accumulating after 2 or 3 years. But I would say that you should start monitoring your T2 starred MRI when the child can lie stable on the MRI table without any sedation, say around the age of 7, 8 or so. That's when we need to really monitor the cardiac. There's no need of giving sedation and then doing the cardiac MRI.
How frequently one should do it once you start
So
moving?
we recommend that it should be done once in a year in a patient who's on regular transfusions.
A lot has been said about this haploidentical transplant, and I've seen units doing it even at age of 18 and 20 years. I mean, what's your take on that? What is the right time or probably the upper cutoff of age group when it should be done? Is there any such kind of thing, or you can do at any age? And what is the difference between properly matched versus haplo from the outcome point of view?
So the best outcome is with a matched sibling donor. There's no doubt about it. And the best age group is between 2 to 10 years of age. Ideally, it should be around 5 or 6 years of age, because by that time, there will be no damage to the liver, no massive accumulation of iron and all those things. So best time is to do that. Now, I'm not saying that matched unrelated donor or a haploidentical should not be done. It is a modality which should be used, but it should be used with great caution in a patient who is ready to accept the morbidity and mortality associated with haploidentical or matched unrelated donor. Again, the ideal age would be to do it below 10 years, because you would not have the kind of toxicity in a HSCT as you would have at the age of 18 or 20 years, although now we have protocols by which we can reduce that mortality also. So my take is that in the year 1988, 89, 1990 plus, when CMC Vellore started doing transplantation, we were seriously worried about the mortality and the morbidity. Similarly, when we started doing liver transplantations, we were worried about the morbidity and the mortality associated with an initial few cases. There was a huge mortality. But look at where we are. All things which are started new, you have to learn. And there's a learning curve with each and everything. And as you learn it, you see an advance. About 7, 8 years back, when we were discussing this issue of MUD and haploidentical, we were sort of clear, no, But now we find that our apprehensions have been allayed to quite a bit. And we can now go in for a haploidentical as well as a matched unrelated donor after explaining to the parents and after being very, very clear that this is not a thing which will certainly fully cure. It may also kill. I'm being very harsh, but may also kill. So we have to be very clear and explain it to the patients in that way.
One question to Dr. Preetham. Actually, the technique of TCD is developed for sickle cell. The whole origin of TCD in the world was for the sickle cell. And now it's being extrapolated to critical care. Now, from the Indian perspective, when do you expect this patient to be starting to monitor for TCD? That's one of the very good modality to prevent the strokes. But which are those potential kind of subset of our cohorts of sickle where we should essentially monitor this patient on TCD?
I'm sorry, I'll probably not be able to tell you the exact number, the exact age at which one should start. But the risk of stroke is quite substantial in the first decade of life itself. I guess it should be started from early childhood, but I will seek help from Dr. Anupam or someone that is Shraddha. I have no personal experience of using, neither I remember any specific recommendation. Sir, if you can help in answering this question.
Again, as you said, that stroke can be a stroke as we understand it with a paresis or something of that sort. But a stroke can also be seen in cases where you do not have any overt sign of a stroke, but you just find a find in the fall in the cognitive functions of the child. So the answer to the question is that in a patient of sickle cell disease, you have to constantly monitor for any decrease in the cognitive functions, one, or an overt stroke, or you can start at 3 years or 4 years by doing a TCT and then do it every year. It's not an invasive test. It's not a test which causes any radiation exposure or anything of that sort. It just requires expertise, although that expertise is not really available in our country, and we need to scale up that expertise also. But as a routine, if a patient comes to you at 3 years or so, do a TCT. If the the speed of the blood is above 70, repeat it after 4 weeks and see if your diagnosis was correct or not. And if it is above 190 or 200, then the patient is in serious trouble. You have to take care of it either by giving hydroxyurea if you have not started hydroxyurea, or to start a chronic transfusion program and follow it up with repeated TCTs.
So actually, TCD is quite regularly commonly done by the intensive care group in India. I mean, we have got a good number of people who are regularly doing on bedside in the intensive care ICUs.
Yeah.
But not for sickle as such. We are doing it for monitoring of our raised ICP patients and brain cell edemas and all those things. Yeah.
So I'm happy.
My
answer to that would be, I'll be happy to take intensivists on board and tell them to broaden their horizon. And
in your unit, Dr. Dhiren does it very regularly.
Yeah,
so
I know that.
Yeah.
I know that.
So it's over to my other colleagues, Chetan, Rajendra. Yeah, Palli, please.
Sir, I am a practicing pediatrician from South India, where G6PD is very uncommon. Unlike from Sir, where the G6PD is very common for Sir. So when we come across acute intravascular hemolysis, what is the commonest cause? Whether autoimmune hemolytic anemia can present as an acute intravascular hemolysis? Whether we can think of AIHA?
Yes, sir. Sir, can I answer this?
Yes, ma'am. Yes, ma'am.
Actually, AIHA is mainly the extravascular, but there is an intravascular component also. It all depends on your agglutinin titer. Especially in a cold antibodies disease, when your IgM titer is very high, it may present as an intravascular as well as extravascular disease. Now, coming to your question, like if it is whether it is a G6PD associated hemolysis, or is it a AIHA? So the simple test is the DCT. So as name suggests, it is if DCT is positive, it's your autoimmune hemolytic anemia. If your DCT is negative, you have a non-immune hemolytic anemia, which can be membranopathy, which can be hemoglobinopathy, which can be your enzymopathy. The thing is, during acute hemolysis, you can't do any test. So even if you do your G6PD titer during acute hemolysis, it will come as a normal. And then you will rule out that this is not a G6PD deficiency. So my take is on that, when there is an acute hemolysis, your DCT is negative, your urine hemosiderin is negative, and you have treated the emergency, then you should repeat the G6PD after 3 to 4 months. So when your acute emergency has resolved and your newer RBC's concentration has come down in the blood, that time the test will pick up the G6PD deficiency.
Then another one thing, madam, mycoplasma, whether it produces warm AIHA or cold AIHA, because sometimes we come across mycoplasma patients, we diagnose by MCHC, increased MCHC, but increased MCHC will occur only in case of warm AIHA, that is when it produces spirocytes. But mycoplasma is known to produce cold agglutinin, whether how it goes hand in hand, whether mycoplasma can produce both types?
No, sir, mycoplasma is mainly responsible for cold agglutinin. Now, as sir has said, even I had missed that point in my slide. I had shown 2 PS. One is warm AIHA and one was a cold AIHA, where lots of agglutinin, RBC agglutinin were seen. Now, it is simple on the CBC. If your CBC is having hemoglobin of 4, 6, 5, whatever, but your MCV is above 130, 140, you have, because it is, Coulter is not seeing your many clumps. It is calculating one clump as one RBC. So your MCV is very high. Your RDW is very high. It is beyond 35. So you have a low hemoglobin, low RBC count, very high MCV, very high RDW. That means you are dealing with cold agglutinin. And the most common etiology is like mycoplasma. MCHC, we don't judge, or we don't see this MCHC parameter for cold agglutinin disease. MCHC parameter we see, which is very high in hereditary spherocytosis. So where there is a loss of central pallor.
Thank you. Thank you.
Actually,
yeah.
MCHC is not a diagnosis of AIHA, is a diagnostic of spherocytosis, whether it is hereditary or AIHA or clostridial infections or burns, anything which causes spherocytosis will lead to a low MCV and a high MCHC, which is again diagnostic of a spherocyte.
So, Preetham, excellent presentation on this one, sickle cell. One word as a general pediatrician, because what we understand, the patient of sickle cell needs two drugs. One, you discussed a lot about hydroxyurea, but what about folic acid? Because we are supplementing folic acid in each and every patient. We know, because there is a erythropoiesis which is coming up, and because of that, there is more degeneration of folate stores. We are giving to contain the anemia. So what about that? Folic acid supplementation is required or not?
My apologies, I probably forgot to include. Obviously, it's a chronic hemolytic state, so folic acid supplementation is routine. Even calcium and monthly supplementation of vitamin D is also recommended. Even zinc supplementation is recommended by this recent Indian College of Hematology, which came out with a national guideline. So zinc, calcium, vitamin D, and folic acid. Those are routinely recommended to be supplemented. Yeah.
Sir, though it is said that this sickle is a hemoglobinopathy, but when there is a quality is hampered, so it is hampered in entire RBC. So there is even a membrane component is there in sickle cell. Why we are giving folic acid? There are two reasons. One is that there is a state of folate depletion because of increased erythroid generation. So that's why we have to do, and we have to give folic acid supplementation for the membrane stabilization. These are the two reasons. That's why we are giving folic acid daily.
And does it affect the action of hydroxyurea or reducing side effect of hydroxyurea, anything like that?
No. It doesn't have to do anything.
It doesn't have anything.
Yeah.
Okay.
In doing the thalassemia trait, we are doing electrophoresis. But now they say that if the patient is anemic, so you may not get proper HbA2 level. So what degree of anemia, because majority of the patients will be anemic. So what degree of the anemia will affect the HbA2 level? Because they said that you treat it with iron and then again do electrophoresis. So what exact degree of anemia is responsible?
Sada, will you answer that, please?
No, sir, please go ahead.
Okay. Well, it's actually, when we say that iron deficiency depresses the HbA2, to my experience, this is more, it is very less seen. This depression is very less seen. So if you do, even if your hemoglobin is 6 or 5 or something of that sort, and you are suspecting hemoglobinopathy, please do your HPLC and you'll find that HbA2 is high. Okay. Number two is that in case your HbA2 is in a range which is just around 3 plus or 3.5, then I would say give your iron if you are suspecting this thing, and be very careful, because a hemoglobin of 5 or 6 can mean hemolytic anemia also, and you may not have to give iron. You cannot give iron in that kind of a situation. This confusion comes more when you have a mild anemia, and you have to differentiate between mild iron deficiency anemia and thalassemia minor. Usme, generally speaking, HbA2 does not get depressed so much that it becomes normal or goes level to that level where we have to think that this is thalassemia trait, but it is depressed because of HB, iron deficiency anemia. So, when you have a moderate to severe anemia, be very careful, ask your pathologist to look for signs of hemolysis and differentiate between IDA and hemolytic anemia. And if you have a hemolytic anemia, please do not give iron therapy along with it. Although as a corollary to that, in sickle cell disease, we do get patients with iron deficiency anemia. This is a peculiar problem which is occurring in India. And that is probably because there is an intravascular hemolysis and there's a loss of iron through the urine in the form of hemosiderin, etc. So that is probably the reason that you get, and as it is, our population is not very iron, full of iron. We have a more or less an iron deficient diet, and that is what the reason is. Because so even in sickle cell anemia, we'd say, एक बारी check जरूर करा लीजिए अपना iron level, because if it is low, supplement with iron.
Yeah, another question is the hydroxyurea in sickle cell disease. We know that it is increases the HbF level and everything. But what is the basic mechanism? Recently, there are also studies. They are pointing that increases the nitric oxide and which is responsible to maintain the level. So now they are getting research in having nitric oxide donating agents. They also use like hydroxide. Is there any point?
Yes, absolutely. You are correct. In fact, Dr. Sorry, the person who spoke, I'm sorry, I forgot the name. That's what happens with age. Person who spoke on sickle cell did explain that in his presentation that it's not hydroxyurea causing activation of HbF, but also the dampening of the inflammatory processes, which helps in patients of sickle cell disease, in patients with sickle cell disease. Am I right, sir?
Dr. Preetham.
Yeah, exactly, sir. Completely concur.
I am sorry, I forgot the
right,
name. I just couldn't place you.
Madam, last question, madam. Shraddha, madam, how common is the acute presentation in autoimmune hemolytic anemia? Usually it is said to be a chronic presentation or subacute to chronic presentation. Whether acute presentation is common or very less common?
No, sir. It's, as name suggests, it's an immune hemolysis. So it has to be acute. Now it depends again that it acute or chronic course. It depends on the underlying etiology. Now, if it is an idiopathic or if it is underlying etiology is your leukemia or PID, it is going to be a chronic insidious onset. But if your etiology is acute febrile illness like a mycoplasma infection or any viral infection, it is going to be acute. The patient will come, like the history is like a typical, there is a prodromal symptoms, fever of 2 days, cough, cold, breathlessness since yesterday, and today morning we saw the child is very pale.
Very pale.
So, okay, the presentation, it depends on the underlying etiology.
Okay, thank you. Thank you.
But typically, childhood immune cytopenias, may it be immune hemolysis or may it be immune thrombocytopenia, presentation is usually acute and rather hyperacute and drastic as compared to, adults and adolescent, where it can be more indolent, chronic clinical presentation. Both in childhood ITP also, you see the child was well 2-3 days back, a prodrome and now comes with a count of 3,000, lots of bleeds. Childhood AIH also mostly what we see is, as ma'am said, and prodrome followed by precipitous acute drop in HB. Chronic presentation is more commonly seen in adults, or sometimes we do see in adolescents also.
Just last question from my side, Dr. Shraddha again. Your immune negative, DCT negative AIH versus PNH, how it will be differentiated?
So basically DCT negative AIHA is very less common. It is seen hardly in 5 to 10%. Now, DCT negative, why DCT is negative when you are saying that there is an immune hemolysis? The first, if we understand the pathophysiology, there is a low titer of IgG. Then there can be sometimes the IgG levels are so low that our tests are not able to detect it, or there can be a pure IgA or IgM type of a hemolysis, where even if because we are testing with IgG, right? So that's why your DCT is coming negative, but your hemolysis is an immune hemolysis. While in PNH, it is paroxysmal nocturnal hemoglobinuria, where the pathophysiology and etiology is entirely different. Even the age group, the presentation, PNH is not that common in the childhood. It is the mainly of the middle-aged and the elder one. So that is how we can differentiate. Irresponsible, if we are asking me PCH, that is paroxysmal cold hemoglobinuria. Yes, that is very common in pediatrics, because it is median age group presentation is the 5 years of the age, and it is mainly to secondary to mycoplasma infection. Now, here, if we give the etiology or pathophysiology, if we see, your antibody is Donat-Lanster antibody, which is directed against your P antigen and which can be picked up. So this is the mainly based on this pathophysiology, we can differentiate it, the cause.
Also, we can pick up the antibody against the
you,
complement, no, madam, complement.
Yeah.
Like DCT against the IgG, like DCT against the complement can pick up this cold agglutinin.
Where, sir? In cold one?
Yes, cold ones.
Yeah, that's what. In cold one, it is the complement mediated lysis, sir. So you have to have, your titer should be high at cold temperature. Titer should be more than 1:40. So your the agglutinin will be positive with C3b, but will be negative with IgG in the cold agglutinin disease.
And we shouldn't talk about PNH as such, but we can easily do a FACT scan for CD55 and CD59 to rule out PNH in these cases, both in the leukocytes as well as in the RBCs.
I think we have overstepped our time. It's more than 2 hours.
Shraddha, how common is the IgA mediated hemolysis? Because IgG is most common.
Yeah, IgG is most common. IgA is rare, sir. Basically, IgA we are seeing where IgA related hemolysis we are seeing mainly when patients are selective deficient of IgA.
I think we have to stop here.
Okay, yeah.
It's more than 2 hours.
Yeah.
And it will just go on and on and on. A wonderful session again.
Yes,
We had really a good insight. Actually, more than update, it was what is established and what is new sort of a session. And almost every aspect of that, whatever is required for the practicing pediatrician, is reasonably nicely covered. Thank you very much, Dr. Anupam Sachdev, sir, for your most valuable time spent here. And you have been always a wonderful teacher. We have attended so many sessions of you. Thank you very much. Thank you, Shraddha. Thank you, Dr. Preetham. And thank you, Dr. Tulatra. Actually, he has left. He had some emergency. Actually, he had come in this uniform of the ICU. So I knew that sometimes we may just leave. But thank you very much. And we have a very kind of a senior, learned panelist here, Dr. Srinivasan, sir. Actually, he didn't get time to make a comment, but thank you very much. His presence is always kind of a inspiration to many. So thank you very much. Thanks, Dr. Palli, Dr. Rajendra, Dr. Chetan, and Dr. Nilima, and Abhay is waiting for his further comment. Thank you all for being here. It's over to Abhay to announce the next week's program.
Can I just say a word?
Self-trained Padagaman, who is equivalent.
Can I just say a word, sir?
Yes, sir, of course.
Knowledge in pediatric hematology is very vast. Only thing he has to get a honorary degree on pediatric hematology. Of course, not only in hematology, but he is good in everything because he is
Absolutely.
and this thing keen learner.
Always.
Sir, who can beat you as a keen learner, sir? I know you are participating in the programs which are run from USA and all those, and I give your example to my postgraduates that it is, look at sir, at his age, he's still following and attending all these sessions. So it's never too late to learn. And I learned from you how to go about it in my further tenure also. Thank you very much, sir.
Thank you, sir. Thank you so much for giving the opportunity.
Thank you. It's over to Dr. Abhay for
thank you, everyone.
next week.
Yes. Yes, sir. Thank you very much. And over to the next week's sessions. And the next week's session is a talk on how not to miss cancers in children.
No.
These are the general tips.
Abhay. That's
Yes,
by
sir.
Dr. Revati on what a pediatrician must know on bone marrow transplant.
Yeah. Okay.
The one which we already had, Dr.
Had changed.
Adra had already had it last time. So we had a reshuffle. So
Okay.
next week program is Dr. Revati from Chennai Apollo speaking on what a pediatrician must know about bone marrow transplant.
Bone marrow transplant. So sorry.
Do join us next Tuesday, 4 p.m.
Yes, sir.
Thank you very much for all. Thank you, Abhay.
Thank you, sir.
Thank you all. Thank you, Arjun.
Thank you.
Thank you very much.
Thank you, sir.
Bye. Yeah.
Thank you. Bye.